Good afternoon, everyone. Thank you for joining our Maternal Infant Health Hub's Midwifery Collaborative today. It's great to see so many familiar faces as well as new folks who may be joining for the first time. So please feel free to introduce yourself with your name, your organization, and your role in our chat box so that we can see who is on the call today. To introduce myself, my name is Armini Pierre-Jacques, and I work as the Community Health and Policy Associate at the New Jersey Healthcare Quality Institute. And I'm also joined by my colleague, Kate Shamzad, who I will let introduce herself.
Hi, everyone. It's good to see you all here today. I know we're spending a lot of time together in this Maternal Health Week. I work alongside Armini at the Quality Institute, and I'm glad to have this program today.
Great. So to provide just a brief background on the Maternal Infant Health Hub, it is a learning collaborative that was launched by the Quality Institute and the Berg Foundation after the release of our Delivering Better Care policy report. So the MIH Hub really focuses on amplifying and advancing midwifery practice here in New Jersey. So one component of the Maternal Infant Health Hub, or the MIH Hub, you'll hear us use that abbreviation a lot today, is these midwifery collaborative meetings. So the goal of our midwifery collaboratives is to bring together key players such as yourself, but also midwives, midwifery students, and other healthcare leaders so that we can connect and talk about some of the best strategies to push forward midwifery practice in our state. I want to also acknowledge that it is Maternal Health Awareness Week, and the theme for this year is Access in Crisis, which really focuses on raising awareness on how accessing maternal health care is really important in order to improve our state's maternal health. And so with that said, today's session is really going to focus on the importance of midwifery integration in clinical settings, and also what does team-based care look like between physicians and midwives. So we'll be hearing from our guest speaker, Holly Smith, who will be able to cover some of that content. After the presentation, there will be time for a brief Q&A segment. So please feel free to drop in your questions in the chat box. You can also private message them to Kate or myself. And you can also post your questions on our Jamboard. So our Jamboard will have some of those questions, but you can also use it as a space to post any of your thoughts or comments as you're hearing this content in the presentation for today. We really want our Jamboard to be a space for you to write and post anything that is resonating with you. So please feel free to interact with us and participate on our Jamboard as well. The second portion of our call is also going to focus on the MIH Hub's Midwifery Toolkit, which was designed specifically for policymakers and legislators in order to promote midwifery messaging and how you can all use this tool in your own work to support midwifery. So we'll be going over that for the later half of our call. Please note that after today's meeting, you will be taken to take a brief exit survey just to assess your knowledge of midwifery after attending this session. And you'll also have an opportunity to provide any feedback on the development on the remaining toolkits that we will talk about a little bit later today. And finally, if you have any technical issues, you can reach out to Kate or myself in the chat box, and we're going to do our best to assist you. So with that said, I'll hand it over to my colleague, Kate, to introduce our speaker.
Thanks so much, Armini, and I'm just really glad that I'm able to be here today to introduce our guest speaker. Holly Smith is joining us. She is a certified nurse midwife with experience in domestic and international women's health policy and program development. As a midwifery consultant, she partners with community organizations, nonprofits, and public health policy organizations to improve midwifery integration in California. She is also the Health Policy Chair for the California affiliate of the American College of Nurse Midwives, where she consults, writes, and advocates for California legislation promoting improved perinatal outcomes. Holly, thank you so much for your time and expertise today, and I'll hand things over to you.
Thank you so much. It's such a nice opportunity to be able to be here today. And I see a lot of names in the chat and some other midwifery powerhouses that are here today as well. So it's just really good to see everybody. And I appreciate the opportunity to be able to speak today. So I'm going to go ahead and share my slides. All right. Hopefully you all are seeing this here. As we said today, we are talking about midwifery integration, and team-based care as a powerful strategy for improving birth outcomes and reducing disparities in outcomes. So I'm hopeful that today, in these very short 25 minutes, that I can get through some really key ideas, the key components of midwifery integration and team-based care, and also identify some concepts of midwifery integration as it relates to team-based care, and hopefully help you all understand how these two things move us closer to eliminating disparities in birth outcomes, and hopefully also help you identify for yourself some challenges and opportunities, whether you are a person in clinical care or a person doing policy work. Hopefully this sparks some ideas. Oops, let's see, my forward button is not working. Also because these concepts kind of are, big ones that we could spend an entire day talking about. I invite you all to take a look at some resources that the California Maternal Quality Care Collaborative has. In fact, we did a 5-part webinar series this last year, actually started in November of 2022, that goes through in much greater detail team-based care, what midwifery integration means, partnering with doulas even, and then community birth and improving transfer of care. So that QR code there will bring you to that, to where those webinars are if you want more detailed information. So let's just start from the beginning and talk about how, at least in California, how we started talking about midwife-led care and midwifery integration and team-based care. So I kind of put a side-by-side here of the cesarean trends of California and New Jersey. I want to say I'm very excited about what's happening in New Jersey. It's almost like you all are a bit of a Trojan horse of maternity care improvement and midwifery integration, which is super exciting. I don't think, well, let's say California didn't see that coming, but we are learning from New Jersey, to be honest with you all. You're doing a great job there. So in any case, this is where we started. You can see that way back in 2014, we realized that there was a cesarean issue, and that's what got us to create our toolkit to support vaginal birth. And we started this entire statewide collaborative to help our cesarean rates trend downward, which happened, and we're very proud of that. Same thing happening in New Jersey. But when we looked at the data a little more closely and parsed it out by race and ethnicity, we saw some pretty large gaps. So obviously, while we were doing really good in the main and generally speaking, there were still some pretty big disparities, especially for Black birthing people. And of course, cesarean is just one indicator of many. When we took a deeper dive into other quality measures, we saw that those same gaps existed, but cesarean, at least for us, got us thinking about what we need to be working on next. So what do we do when we're up against this sort of what we call in public health, this wicked problem, where there is this vast, confusing network of interconnected concepts, where clearly just clinical improvements alone won't solve the problem, right? We see structural racism and implicit bias. There's, for those of you who are policy folks on the call, all of these policies that need to be implemented or changed or improved that relate to health related social needs and those upstream determinants of health. Payment reform, in my opinion, is probably one of the biggest things we need to work on still. And we're doing all this in this environment of scarce resources too, right? We've all heard about the many hospital closures happening nationwide. We have an insufficient workforce, and we're trying to make these changes in real time, systems redesigned from telemedicine to community-based care, which is all fine and good, but we're finding that those things need to be tweaked and improved as well, right? So just so much going on. And you can see here when we talk about those health-related social needs, here's what each patient is bringing to their clinical visit with them, that as clinicians, we clearly can't solve all of these problems just from a clinical improvement standpoint, right? But lucky for us, it really does feel like, and I hope it feels like to you all as well, that we're at a real tipping point for change. 5 years ago, 10 years ago, definitely, but even 5 years ago, it feels very different from that. And now that the term birth equity has come into our common vernacular, really means that we are in a very different place. And there's no shortage of organizations and state and federal agencies and nonprofits and clinicians, et cetera, that are working on each of these things. So that part is a good thing. So let's look at birth equity then. The definition, and I know many of you are familiar with this definition, it's from the National Birth Equity Collaborative, and it is the assurance of the conditions of optimal births for all people and a willingness to address racial and social inequalities in a sustained effort. What I really love about this definition is that obviously the folks who created this definition thought long and hard about the exact words, because it's not saying that birth equity is when everybody has the same outcomes. Surely we want to get there. That is the point, right? But what it's saying is that we have the responsibility to create the conditions that will get us there. And to do that, there has to be a willingness to really look at those racial and social inequalities. And so when you think about birth equity, there's so much more here that does not look like the typical quality improvement initiatives, right? This is a very aspirational definition. It takes significant emotional intelligence and radical empathy. We have to be thinking innovatively about systems change. We have to consider all those upstream social determinants of health. It requires us to break our bias about what we thought modern medicine could do and what it really can't do nowadays. It means a trauma-informed approach. So that really doesn't look like typical clinical quality improvement processes, right? Which are outcome orienting. They have target goals that oftentimes are just kind of made up to get us to something that's good enough. We often start with the low-hanging fruit. We stop and start these initiatives. And oftentimes, at least in the clinical setting, it is about the behavior change, but we aren't really changing the hearts and minds of folks. And to get to birth equity, that's what we have to do. So this is a really quite a different place to be in. So the work must be intentional then, right? We have to consider community needs and wants in our approaches to quality improvement. We need to incorporate improvement measures that evaluate other things besides just the outcome measures we typically look at. So like respect, dignity, implicit bias in childbirth. It requires humility to accept that what we are doing right now isn't working for everyone. And we have to use all the tools in the toolbox. We cannot rely anymore on the same old stuff. So that means, and you can see that here in bold at the bottom, we have to utilize those strategies that consider the root causes of disparities. And that's how we got to, it was kind of a 7-minute way to get to how we got to concentrating on midwifery care and the integration of midwifery care into our current system and team-based care. Because midwifery is a philosophy that is rooted in building relationships and respect for patient autonomy and their values. And you combine that patient-centered approach with the best medicine and the best doctors in the world, and you end up with this highly relational model of care that's structured to give the right care at the right time based on each person's unique needs. And I'm not going to go through these things, but I just want to note, because this group clearly knows why midwifery care is important and what it entails and what the outcomes are, et cetera. But these QR codes here are QR codes to some really great videos. One is on the history of midwifery in the US, and the other talks about kind of the relationship and that the tense dynamic between midwifery and medicine, which in my opinion doesn't need to exist any longer, but gives some good background. And of course, the benefits of midwifery care, we are all familiar with that. So let's just jump then into what is team-based care. A really great resource is this one here from ACOG. It's called Collaboration in Practice, Implementing Team-Based Care. And it's great because it's directly from ACOG, and the point is to give examples of what it means for midwives and physicians to work together in a team-based approach. And their definition here is that a team-based model of care is one that strives to meet patient needs and preferences by actively engaging patients as full participants in their care, while encouraging all healthcare providers to function to the full extent of their education, certification, and experience, which is not something that is available to midwives in all states just yet to be able to practice to that level. But That is part of team-based care. It is also where relationships between the midwife, physician, nurses are negotiated by shared norms and visions. And it's where each team member does have the knowledge and skills that they need to contribute to the work and to the problem solving that are the purpose of the team. Oftentimes you'll hear things interchangeably like collaboration, right care at the right time, co-management even. These are all concepts of team-based care and are parts of team-based care, but aren't exactly team-based care. And I'll tell you why in just a sec. The ACNM also has a definition of collaboration. Again, collaboration is not team-based care. It's a part of team-based care. But this just goes to show that our sister organizations are really trying hard to get to the meat of what it means to work together in this way. And you can see here that the ACNM concentrates on these are professionals jointly managing care. They share authority, which is also probably one of the hardest things under the team-based model, and that it is a way of thinking and relating that is totally different than the typical model of care. So it's really a paradigm shift in how we interact with each other. So now I'm going to go through the key principles of team-based care. And for the clinicians here, I would really encourage you to think about each one of these individually and ask yourself, is my organization doing that? Because it's really easy to be like, yeah, we do team-based care all the time. We have midwives on our unit, so we're integrated. And that's actually not what that means. Sometimes we confuse integration with simply utilizing midwives. So I really encourage you to think about each one of these just as you would in a like a strategic planning meeting. Like, are we actually accomplishing each of these things? So the first is that the patient is the integral core of the team. So patients and families are actively engaged as members of the team, if not the key member, right? So the team must have a common commitment to patient-centered care. I really love the quote, "Nothing about me without me." That's Dr. Don Berwick's quote about team-based care, or I should say patient-centered care. So the locus of control is truly with the patient, and the patient has a choice in all matters without exception. And I can imagine that for some organizations and some places, this might create a real disruptive shift in how patient care is done. Also, the team has a shared vision. So you have to really sit down, make a strategic plan, identify what your shared goals are. For example, if you have this shared goal of really valuing physiologic birth, is that our shared vision? How do we get there from here? So you have to collaboratively create a roadmap to guide the expectations of how things are done. And it requires a lot of unity. The team is an integrated body of knowledge and skills that are working together towards a common goal, not individuals simply practicing in parallel. Role clarity is optimal to team functioning. So this means respect for each other's expertise, understanding each team member's scope and role, as well as understanding that great minds don't think alike. That's a wonderful quote from a collaborative practice team-based care paper that came out of San Francisco General Hospital and UCSF way back in 2011 now. But essentially, you're trying to work together as a cohesive team with a cohesive vision, but while still respecting that we may have different ideas and different ways of getting there, and just respecting what each person brings to the table and maximizing that expertise. Also, clinical guidelines are really great for role clarity. That is obviously the language and communication of team-based care. All team members are accountable to their own practice and to the team. So everyone is committed to consistently practicing within their scope of practice. Everyone's committed to continuous learning inside and outside of the clinical experience, and you hold each other accountable. Just going to check my time real fast. All right. Effective communication is also key, of course. I mean, I think that's probably an obvious one. Adopting standard frameworks for how patient status is communicated is the most obvious thing, but also trust and honesty and transparency and timeliness of communication, and involving ourselves in that idea of a just culture, meaning that we're able to share our ideas without retribution, or able to exist in that clinical experience with knowing that folks are going to keep clear-headed and calm-headed during those moments. And it also means skilled communication with the patient. So that's different than informed consent, right? Shared decision-making is different than informed consent. So is everyone in your team trained on shared decision-making and how that communication occurs? And then finally, team leadership is situational and dynamic. And that is probably the hardest thing when most organizations work in a hierarchy, right? And we're asking for that hierarchy to be flattened or at least to be fluid. So high functioning collaborative practices have developed beyond a hierarchical structure. No provider type is superior to the other. This requires experiential learning and building respectful relationships over time. And that is how you get to team-based care, very quickly in a nutshell. So midwifery integration, what does an integrated system look like? And midwifery integration, again, is not team-based care in and of itself, but for midwifery integration, as I'll get to in later slides, to really be happening, team-based care has to be part of that as well. So what does it look like? It's actually quite difficult to define because there is no universal definition of midwifery integration, but we can definitely draw from other definitions, integrated healthcare generally, for example, accepted definitions of integrated maternity care. From ACOG's maternal levels of care, we can glean that there's that integrated care relies on enhanced communication and cooperation and assessing risk on an individualized basis. So all the things that kind of were also in those components of team-based care. Other countries can serve as a model as well. But what we have found, at least in California, working on this concept with community-based and hospital midwives, is that there is both micro level, meaning clinical level, and interprofessional level integration, and then macro level integration, or integration on the state and federal level. So why does it matter, though? Couldn't we all just continue in a system of care that is occurring in parallel, and midwives see the patients they want to see and physicians see the patients that they want to see? In fact, integration really does matter. And one of the studies I always point folks to is this one that came out of the Birthplace Lab by Saraswati Vidam and her colleagues that mapped the integration of midwives across the United States in all 50 states and looked at the level of integration and how that compared to their outcomes. Because this is such a nuanced study, I think it's better perhaps if we just explain it with this next video. So if you give me 1 second, I'm going to change out.
When midwives are a part of the system that provides maternity care, how does it change health outcomes? Are those outcomes impacted by race? A multidisciplinary team of experts in research, legislation, and birth first developed a scoring system and then carefully ranked every state in the United States to find out where midwives are available and where midwives are integrated to practice within the healthcare system. The team scored each state on items like laws and regulations that support or limit midwifery, like the ability to prescribe medicine, access to insurance coverage, and smooth access to advanced care when needed. The results found that no state got the maximum score of 100. But states that scored higher at integrating midwives into the healthcare system were associated with higher rates of spontaneous vaginal delivery, higher rates of vaginal birth after cesarean, lower cesarean section rates, lower preterm births, higher breastfeeding rates, fewer interventions during birth, and fewer neonatal deaths. This is the first time these important connections have been established. In states where more Black babies are born, integration of midwives is lower compared to states where fewer Black babies are born. Access to midwives and density of midwives are also significantly lower in states where more Black babies are born. These findings highlight racial disparities in integration, density, and access to midwives. This is particularly critical given that Black families are more likely to experience complications and infant death. The researchers' conclusion: greater integration of midwives is associated with improved outcomes for families across birth settings, even when taking into account the impact of race. To learn more about your state score, visit birthplacelab.org.
Right. So that study concentrated on those macro level integration concepts. Do midwives have admission and discharge privileges in their state? Can they prescribe medications? Can they practice to the highest level of their education and training? But integration clearly looks like other concepts as well on both the macro and micro level. We put together, by we, I mean the California Maternal Quality Care Collaborative, put together a task force of midwives to look at what does it look like for you in your practice setting if integration really was happening in the state. And here's what this peer group came up with. There's a culture of interprofessional partnership, meaning easy access to physician consultation and collaboration, including interprofessional education. It's also just overall concept of valuing midwifery and physician care as equals, meaning that concept of the right care at the right time. It means community and hospital midwives are represented in the state perinatal collaborative. All midwifery credential types are recognized in your state and regulated according to ICM standards. Not all midwifery credential types are recognized in California. We recognize certified nurse midwives, certified professional midwives, but we're working on the certified midwife part of that. Birth centers are licensed, accredited, or meet equivalent standards. It means guidelines for safe, efficient, respectful transfer exist and are created through a collaborative process, meaning that transfer between the community space to the hospital when needed. There's sustained growth of community midwives, including BIPOC providers. It means that outcomes data specific to midwifery outcomes are readily accessible. Midwives have admission and discharge privileges. I'm happy to say that has just changed for California, start as of January 1 of this year. State law allows midwives to practice to the full extent of education and training, including prescribing all drugs and devices in their scope. And there's equal reimbursement and coverage for midwives and birth centers, and home birth for that matter, by all payers. So you could also do the flip of this and think about midwifery integration in the sense of, if this is happening, then that means we haven't achieved midwifery integration yet. So if policy and practice is founded on supervision rather than collaboration among colleagues, then we could easily say that midwifery integration has not been attained. If patients receive disrespectful care or judgment when transferring to the hospital from a community birth setting, or if hospitals in your region refuse community birth transfers, if there's a refusal to believe that diverse care models are critical to addressing the root causes of healthcare disparities, if midwives are privileged at your facility but function as extensions of physicians, meaning they are unable to practice the midwifery model, if midwives can't prescribe or access the medications they need to provide safe care, if insurers don't cover community birth, that would mean midwives are not easily accessible to the public, or if they otherwise engage in unequal reimbursement. If CNMs are licensed in your state, but not CPMs and CMs. If you value or trust one midwifery licensure type over another, I can say that for a long time, our state perinatal organization really was hyper-focused on CNMs. Of course, that leaves out the majority of home birth and birth center births in our state. So I'm glad that we are moving towards a more integrated model in that way. If midwives in your region have a restricted scope of practice below their actual education and training, that's very problematic, as the video showed. And if hospital midwifery is embraced but community birth is disparaged, these would all be examples of integration not being achieved. So now we can just kind of it's easier to give some examples through my own state in California. And you can think about how this compares to New Jersey as well. So here we have in California state funding for a midwifery education pipeline that was just funded a couple of years ago. We have a growth of community midwives and BIPOC providers since supervision was removed. There's definitely strong advocacy for equal reimbursement and contracting. We have an entire midwife-led care, I should say a Medi-Cal collaborative for midwife-led care in Medicaid that is happening right now. We're amending those arbitrary state laws that restrict access to midwives. There's certainly a rise of midwifery advocacy by community organizations and policymakers, much like what's happening right here in New Jersey. And of course, California is a reproductive freedom state, embracing patient choice on all levels. But on the darker side, here's what we haven't done. There are actually few active endeavors to improve collaboration and transfer between community birth sites and the hospital. In fact, that's just getting started and ramping up. Hospital midwifery is clearly still elevated above community birth. Commercial payers won't cover community birth or midwifery care in many cases. Disrespectful transfer of care from the home or a birth center to the hospital happens pretty regularly. There's also a dearth of available training sites for midwives. We don't yet have readily accessible midwifery outcomes data, but we're working on it. And we also have other state laws and regulations that prevent patient choice in childbirth. And while we now can have admission and discharge privileges, we are unable to obtain medical staff membership at this point. And so all of these things have worked together, unfortunately, to reduce the size of the California provider network. It has eliminated or reduced patient choice for where a person can birth. This adds up into decreasing safety and quality of care overall. And it also increases medical intervention at significant cost to the state. And ultimately, the effects of all of these things are carried mainly by BIPOC patients, socially disadvantaged folks, and those who are geographically isolated. So we do have some resources for these micro-level integration, meaning that clinical and interprofessional integration levels in the CMQCC toolkit to support vaginal birth. We include administrative, educational, and clinical strategies for your hospital. And by the way, these are not all the strategies. We just kind of want to zoom in on a couple of things here. But stuff like, first of all, very first thing, are there midwifery attended births at your facility or within your medical group? Do community birth midwives have privileges at your facility? Meaning community birth, meaning birth center and home birth midwives, do they have privileges at your facility so that they can transfer their own patients when necessary? Do your policies enhance collaborative partnerships, or do they rely on supervisory relationships? Do midwives lead QI projects at your facility? So hopefully these things are just kind of getting you thinking about how integrated on the micro level at your organization. Is your department engaged in projects that improve safe patient-centered transfer of care, meaning from the community setting to the hospital? And are you fostering a departmental culture that values reduced intervention and midwife-led care for low-risk birthing people? Because honestly, midwifery can't survive as just a physician extender model. So the organization does have to uplift the concepts of reduced intervention for those low-risk folks if they want that, and that will sustain the midwifery practice there. All right, so that is it. Thank you. Feel free to email me at this email if you have questions.
Thank you so much, Holly. That was really good content. And I'm sure, like many on the call, my mind is already churning, I think, and doing somewhat of an evaluation of our current state of the state. We did get a couple of questions that came in. The first was on our Jamboard. What can Medicaid do to really support team-based care?
Yes, that is a good question. In fact, in California, we are part of a 5-state collaborative through the Institute for Medicaid Innovation that is looking at what would it take to improve midwife-led care for Medicaid enrollees. So the first thing is, it might be a little bit different in your state versus ours. All of our pregnant Medicaid patients are served by Medi-Cal managed care organizations. So there's the state agency for Medicaid, but it really flows through managed care organizations. The first thing is to think about what are the significant barriers for midwives to become enrolled as a provider. Sometimes these barriers are very simple and are just, for example, in California, our application still said you had to name a physician supervisor many years after not needing a physician supervisor, which was just like obviously the first major barrier that midwives came up against in just trying to become a provider. There were code lists in Medi-Cal for what midwives could bill for. And those code lists didn't include everything that was in our scope. For example, Rogam was not a reimbursable medication. A life-saving medication was not reimbursable under Medi-Cal. So just looking through from the start, some of the very basic kind of institutional barriers that would keep someone from enrolling as a provider and then being able to bill for the things that are very standard within their scope. The second then, and actually these are kind of in no particular order, just kind of going through conceptually, reimbursement obviously is a big one, and that clearly differs between states, but I can tell you in California, Medi-Cal will pay $500 for a birth, and in general, just $2,000 total over the pregnancy. And of course, that changes dramatically if a client were to transfer care. From the home setting or the birth center setting to the hospital, you lose that facility fee. So there's lots of reasons. Under reimbursement is one thing, but then not being able to be reimbursed at all for care should the midwife do the right thing, like transfer the patient at the right time. So that's going to take working with policymakers to improve reimbursement and also improving reimbursement structures, right? Midwifery care cannot follow the typical medical model, which even as much as we are trying to change to value-based payment, conceptually still you have to see a lot of patients to make more money, right? And that is not at all consistent with midwifery care. We need longer visits to build those relationships. It's all about focusing on the patient's values and their needs. And because the midwifery model is all about being that enhanced care manager, meaning that, you know, in some cases, the person who's setting the client up with their whatever counseling they need or whatever they need to get the transportation or working on whatever's happening in the food insecurity realm. All of those things are being done by a midwife, which slows down how many patients you can see, right? And so a volume model doesn't work, which means that these low reimbursement rates are even more how should I say, even have more of an impact on midwives than they may on other practices. So those are just a few things. I think I could go on about the Medicaid thing for a while.
Yeah, thank you. And I'm seeing lots of activity in the chat, I think certainly reflective of a lot of the macro and micro components that you've shared. I'm just wondering if we could focus, I know you gave us some great sort of starting points, jumping off points to evaluate, you know, Medicaid's support of team-based care. I'm wondering if we could think a little bit more on the micro level. What are some of those first steps that a health system needs to take or a hospital would need to take to really focus on team-based care, and who needs to be at that table beyond, you know, midwives, of course?
Yeah. So the first thing is sitting down with like you said, not just the midwives in the group, but whoever will be functioning in that team-based model. So all providers should be present at the table. This shouldn't just be something that starts at the top and stays at the top. There's a lot of good intention sometimes when we say, okay, let's we are going to remove supervision from our policies and protocols. We're going to replace that word with collaboration, and we're just going to let folks know now that we collaborate. Of course, that doesn't really work, because there are different personality types. There's different ways of being trained. The majority of medical providers are not trained in an interprofessional way with midwives. So it does mean bringing everybody to the table and simply beginning discussions about, like, what does it look like to implement a team-based model of care? First of all, what is our vision? As I said previously, as one of those key steps. What do we want to achieve? It's really, honestly, a strategic planning for OB and midwifery providers. Because if we can get on the same page with what our goal is, then we can create structures and communications and policies that reflect those goals. I think really the biggest one, and this is totally a midwifery thing to say, but it's tincture of time. Put in the time. Because those relationships don't just happen automatically, and that trust of each other, and this goes both ways between midwives and physicians, physicians back to midwives, that doesn't just happen overnight. So it does take a certain level of relationship building. And then if you have a vision that you've created for your organization, then you're also only going to hire people who can be consistent with that vision. Yeah, hopefully that gives some good starting points. But I definitely think collaborative practice, I should say collaboratively made policies that reflect how physicians and midwives will interact and communicate are also really important.
Talking without unmuting. Thank you, Holly. We have
Sure.
just one last question before we wrap up this portion of our collaborative. Coming in, it says, what incentives do we offer physicians to embrace this team-based model, and how might this dovetail with research showing that midwives burn out less in a caseload model?
Yeah, so that's really true. I was thinking through this very question yesterday, in fact. It's unfortunate that we have to have incentives to do the right thing, right? But it is, frankly, how life is. This does not just go for physicians. This stands for midwives. This stands for the rest of the world in general. Sorry, my daughter is home from school today, so I'm just purchasing a Minecraft game for her. so, um, so yeah, so what are the incentives? I think burnout is a big one. Preventing burnout. Physicians must feel so stressed out to have to be the supervisor of everybody, to lead the care of everybody. In the old team-based model as a physician-led model, right? I can't even imagine what, and then to also be kind of like the buck stops with them, right? When there is an emergency, there's just so much weight. There is an incentive then to share that stress across the board, because the majority of folks are essentially healthy, low-risk people, and these are precisely the folks that are meant for midwifery care. I think that we can get into some problems there, though, if we only focus on burnout and stress, because what happens then is there's a potential for midwives to simply be hired to be physician extenders, to like take the load off, to be in the hospital so that the physician can go do this other procedure or get some rest or whatever it might be. So that's the thing you want to avoid. In creating an incentive around that specific thing. But the incentive might also be that we are all humans working towards a better place for all birthing people in this nation. And so we now have the data that shows that working together is better than working apart. So hopefully there's also that concept of changing the hearts and minds of folks, and the policy people on this call and the community organizations on this call. I really just give you all credit for being able to stand up for that human rights approach.
Well, Holly, thank you so much for your time and expertise today. I am seeing a lot of requests for your slide deck, and so I believe we'll be sharing that out in our post-session email. And I think you teed us up really well for the next part of our collaborative meeting, where we're really going to talk about how do we get this important messaging out, really that would support integrated midwifery. So thank you, Holly, so much. And Armini, I'll turn things over to you.
Thank you.
Great. Yes, thank you so much, everyone, for just submitting all of those questions and for just that really interactive discussion. So this leads us now to completing a really brief word cloud activity. This activity will allow all of us to hear from you. So with that said, I will be sharing my screen so that we can all answer our first question together as a group. So our word cloud activity is posted on the screen. Our first question is this: what does advocacy look like for midwifery care? And so to answer this question, I invite all of you to either scan the QR code that is on the screen using your phone, or you can also click on the link that is provided on the chat box. That way you'll be able to participate and answer the question, what does advocacy for midwifery care look like to you? And again, this question really transitions us into the purpose of our policymaker toolkit. So we'll just give everyone a few minutes just to answer that first question. So some responses are coming in. Number 1, engaging legislators. Number 2, consistent and frequent messaging, which is really important. I think that will kind of prepare us with thinking about this toolkit and the purpose of its development. Building strong relationships, centering patient voices, updating antiquated legislation, having support for all midwifery types, CPMs, CMs, and CNMs, and policy and access, promoting policies that reduce barriers, also constant volunteerism, and then also following up with the patient. A lot of responses coming in, yes. Systems and organizations that promote midwives, as well as the midwifery model of care. And finally, supporting all midwives. So great, it's great to hear what advocacy looks like. And it definitely shows that it can take on different forms. We'll be moving on to our next question for the poll. Our next question is this: how can policymakers and legislators support midwifery practice here in New Jersey? So again, if you want to participate, feel free to scan the QR code on the screen, or you can also click on the link that is provided in the chat box. Our first response: promoting independent practice for all midwives. Equitable reimbursement for birth center and home births. Reimbursement, passing legislation for full practice authority. Midwives should be licensed by a midwifery board. Again, passing fair legislation and allowing full scope of practice. So great, thank you everyone for participating in that poll. We'll definitely send out all of these responses as well in our follow-up email. And so if that's said, this leads us just thinking about the priorities of the Maternal Infant Health Hub and why the development of this toolkit is important. So if that's said, I'll just share my screen. Great. So again, this kind of leads us to think about some of the priorities for the Maternal Infant Health Hub. So these are our 3 main priorities. The first one is focusing on raising public awareness for midwifery. And that really focuses on educating key groups, such as the public, healthcare stakeholders, legislators, and more, and educating them on why midwifery care is so important. The second priority for the MIH Hub is assessing the regulatory landscape of midwifery. And so what that means is really just analyzing a lot of the policy levers here in our state, and how do those policy levers either impact the profession or how it drives different barriers. And then the third priority for the Maternal Infant Health Hub is really just promoting more midwifery education and training, and thinking about the different opportunities of how we can spotlight new pathways for people to enter the midwifery profession. So we're really going to focus on goal number 1, addressing the public awareness of midwifery and how that toolkit really addresses that goal. So just to provide some background on the development of this toolkit, the research for this toolkit began by looking at all of the existing public awareness campaigns that exist that either exist domestically in the US or internationally, and how they promote midwifery care. So from there, all of those campaign messages were analyzed, and they were then categorized into 4 audiences that align with the first goal that we just mentioned. And those 4 audiences include consumers, educators, healthcare providers, and then also policymakers. A lot of the campaign messages that we found vary in messaging. So some of them talked about really increasing the midwifery workforce by investing in employment, the retention, and the training of midwives. Some of the campaign messages talked about educating consumers about the benefits of midwifery care. Some of the messages also talked about increasing the resources and support for midwives, especially with the challenges that they may experience in the field. And then finally, urging policymakers to take action so that they can strengthen the profession. So from there, the toolkit really took all of those campaign messages and adapted them so that they can be more reflective of New Jersey's current needs. So here is just a summary of all of the key messages that are provided in the toolkit. All of these key messages are really strategic language that policymakers should know and recognize when it comes to midwifery practice. So the first one is midwifery improves health. And so really policymakers should know that by prioritizing midwifery and increasing the access to midwifery services, you're ultimately promoting safer childbirth experiences. The second key message is that midwifery reduces maternal health disparities. And so we really want legislators to know that by supporting initiatives that promotes diversity in our workforce and expanding midwifery services, especially in underserved areas, that ultimately reduces maternal health disparities. The third key message is that midwifery aligns with patient autonomy, and that autonomy and choice is a really important component within the midwifery model of care. The fourth message is that prioritizing midwifery can be done through state policies, and that state policies can be used to promote equitable reimbursement, workforce diversity, and then also increasing midwifery services. And then finally, prioritizing fair payment for midwifery services is really important because that ultimately helps control healthcare spending. And so altogether, this is just a list of all of the key components that are included in the toolkit. So number one, this toolkit includes a call to action. It's really calling on legislators to support legislation that eliminates the barriers in midwifery practice. The toolkit also includes the key messages that we just talked about. Those key messages can serve as talking points for some of the priority areas in midwifery practice that policymakers should ultimately know and recognize. The toolkit also includes sample social media posts, different graphics and captions and hashtags that can be used across different platforms. There's also a newsletter and email text. So this text can be used to share the toolkit via email or newsletter. There's also a link to the Maternal Infant Health Hub's resource page. Our resource page definitely contains a lot of content from previous midwifery collaborative meetings and our previous spotlight meetings. And then there's also a section for additional resources, and that includes a link to the Delivering Better Care report. So talking a little bit about the social media messages that are included in this toolkit, all of the messages were really taken and honed in from those key messages. And so each of the social media posts can be adapted and it can be customized across different social media platforms. Another important component to these messages is the hashtag prioritize midwifery. So that hashtag will be used as the central framing for all of these messages. And it's really meant to call attention to policymakers so that they're supporting legislation that amplifies midwifery care. And so now moving on to the instructions on how to use this toolkit. So in honor of Maternal Health Awareness Week, this toolkit has already been launched on Tuesday, again, with the main goal of increasing public awareness around midwifery. And so individuals or organizations can share the social media posts that are included in the toolkit, and they can use that hashtag prioritize midwifery to increase the public awareness around midwifery care. You can also tag the Quality Institute and the Burke Foundation in your posts as well. So this policymaker toolkit is available on our resource page, and it can be shared broadly across your networks. And again, this toolkit was really developed to be user-friendly, and it's meant to be adaptable across all social media platforms, as well as email text as well. And so now just thinking about some next steps. The toolkits will be developed for the remaining audiences in alignment with goal number 1. So those remaining audiences include consumers, healthcare providers, and also educators. So in today's exit survey, all of you will have the chance to provide feedback on some of those key messages that should be included for the rest of those audiences. We really want you to think about what are some of those main messages that consumers, healthcare providers, and also educators should know when it comes to midwifery care in our state. So again, all of you will have the chance to provide that feedback in our exit survey, and you can also send your feedback to the Quality Institute staff via email. And so with that said, that sort of leads us to wrapping up just this call. We wanted to thank all of you just for your dedication in joining today's call and just thinking about how we can promote midwifery in our state of New Jersey. And so again, just as a reminder, this follow-up, the slide deck, and then also the recording will be sent out in our follow-up email. It'll also be posted on our MIH Hub resources page. And our resource page also contains previous slide decks and recordings on our previous calls. And so it's really just meant to serve as a resource to continue your learning and education in midwifery. And it also can be shared with your colleagues as well. Our policymaker toolkit, again, is posted on our resource page as well. It's also posted on our Zoom chat, so it is available for use for all of you. So please feel free to post those social media messages in honor of Maternal Health Awareness Week and even the weeks leading afterwards from that. Again, the goal of this toolkit is really just to raise more public awareness around the value of midwifery care. And you can also use the hashtag Prioritize Midwifery and tag the Quality Institute and the Burke Foundation. Please also keep in mind some of our upcoming events for the Maternal Infant Health Hub. Please save the date. The Maternal Infant Health Hub will be having an in-person convening, which will take place on Thursday, April 25th from 10 to 3 p.m. It'll also feature guest speaker Magda Shaler-Haynes, who's going to do a deep overview on our policy brief that is going to talk about some of those policy levers and how that impacts midwifery practice. We will also have our policy spotlight meeting that is scheduled on Monday, June 24th from 1 to 2 p.m. And this session is going to focus on the regulatory landscape of midwifery as it aligns with the second goal for the Maternal Infant Health Hub. And so the registration link for that is already posted on the Quality Institute website, and it will also be included in our follow-up email. And finally, as our final wrap up, again, as you exit today's call, you will be asked to take a very brief exit survey to assess your knowledge about midwifery after attending this call, but also to provide your feedback on some of those key messages for the rest of our audiences. So we want to hear from all of you just on any feedback that you may also have on other components that should be included in this toolkit. And so with that said, we just thank all of you for your time and just for joining today's call.